fractures. These days we have been doing it regularly, but I stick my neck out and tell you that this is not what I am recommending as a normal mode of treatment in hip fractures, trochanteric fractures. I and you always should prefer a fixation in such fractures. But at times, because we have available implants, we have available techniques now that we can do a good arthroplasty in such fractures. And since these are fractures of the aging population and it's a major health issue, in our orthopedic wards, we see them very commonly. And as it is a usual fragility fracture, bone quality is very poor. You need them to be walking very fast, and the more you subject them to agonies of multiple surgeries, more you have problems in them. So salvage becomes very difficult, and with litigations, and we are surrounded all around by all hazardous elements. So arthroplasty has become an option now in such fractures, but I strongly recommend that you should always try to fix the original bone and get a good fixation rather than an arthroplasty primarily. I belong to an era where I have seen best of both worlds. During my residency, the dictum was in a trochanteric fracture, you put them on traction and tell the patient to count 100 days. The day 100 days are over, his fracture is united. Whether it is malunited, whether it is not united, it doesn't matter. But I am very honestly agreeing that was how I started orthopedics. Then we have all these implants, and the last implant I did in my own mother not very long ago. These extracapsular fractures, subtrochanteric fractures, they are usually, as I am trying to emphasize, with internal fixation, and that should be the treatment of choice. And basically, there are, in these older age groups, in a younger age group, you might want them to weight bear very quickly, but in older age groups, you are a little skeptical, you are a little apprehensive whether you should allow, and with fixations like this, it becomes a little more difficult. The extrapolation of fracture neck femur, where avian is a very strong possibility, arthroplasties have been ushered into as the to avoid complications in a fracture neck femur. So we have because the fracture is just 1 inch away from that, so we have extrapolated the arthroplasty in such fractures. But mind you, that 1 inch is a very big difference. There is a lot of difference in technique 1 inch away from the neck femur fracture. So complications can be very mind-boggling. You have implant failures, you have collapse, you have head cutouts. So then arthroplasty, obviously, as Dr. Milind said, becomes the only choice. So in certain fractures, as I told you, these are fragility fractures where bone quality is very poor. Your metaphyseal, the base of your implant, the thing which holds the whole implant together is comminuted, and there is loss of bone there. So many fixations do fail. So arthroplasty becomes an option in such fractures. So in intratrochanteric fractures, mortality, as you all know, is very high. It is around 10%. People die within 1 month, and around 1/3 within 12 months due to whatever reasons, because they are morbid patients. So, but I'm not again suggesting that there's an advantage of arthroplasty over fixation. No paper has proved that arthroplasty is way ahead, but only thing is that it might be able to give you short-term decrease in morbidity in these fractures. So aim always is to operate on these fractures to allow them fully weight bear, because these are very morbid patients. They hang by a very thin line of normalcy. The moment there is a fracture, they start tumbling down, and you might lose them very fast. So it is very important that they are up and about as soon as possible. So recommendations, so you have to do all this in the ward. So to get them onto the table, it's a very difficult task. So coming to the technique per se, arthroplasty in intertrochanteric fractures or extracapsular fractures, I have divided into 3 zones, like indications, implant, and technique, areas where you need to look at. So types of fractures where you can use an arthroplasty, obviously unstable fractures where there is a lot of comminution, where your medial calcar is comminuted, there is deficiency of medial calcar, and the lesser trochanter is broken, GT is broken, and also reverse oblique fractures. These are very difficult fractures, and the present generation implants, even the PFN, although it has made a big change in the treatment of these fractures, we can do it percutaneous and with a very small incision, but then it has an inherent, if your lateral wall is not well intact and if your medial wall is comminuted and collapsed, your PFN might fail. So these type of fractures probably would need a look to consider an arthroplasty. Instability, absence of, as I told you, medial support, any fracture which is something like this in an 8-year-old fracture, probably a fixation would be hazardous. And I think still the first choice may be fixation, but then you have to explain it to your patient, you have to discuss it, because these days I think it has become very important that you discuss your preoperative plan, not like earlier days where doctors were considered gods, and even if it failed, you would probably be able to salvage them. But these days you have to discuss the whole thing. So in such fractures where there's a lot of comminution, proximal area, the metaphyseal area is badly comminuted and you are sure that you can't salvage it, probably an arthroplasty becomes an option. So they may unite in spite of the your good fixation, but then at the end you might have a picture like this, so you still have a arthroplasty to consider. Any delayed treatment probably could also lead you a lot of varus here, and you can see and there is no medial wall. Even if you do a good fixation, you will probably need a graft or probably need a very strong implant. So an arthroplasty in probably an older age group probably would be an option. So good implant with a good distal hold and a refixation of the trochanter probably can work and can last more than a decade. Then next indication probably would be a non-union. Many fractures, they don't unite in spite of a fixation, or whether they are neglected or probably fixed. We can see these x-rays very regularly. So again, arthroplasty in such situations becomes a step ahead. Malunions again with associated non-unions again, rather than leaving them alone or trying to venture a refixation, probably an arthroplasty could be a good option and make them walk immediately. So how does a repeat osteosynthesis fare with the conversion arthroplasty? So it takes for a repeat arthroplasty almost 3 to 6 months. Weightlessness, you don't have to allow them to weight bear. Then the success rate again in elderly maybe even after the second surgery may be poor. Then difficult surgery to do a refixation, probably you have already a big void in the head, your implant doesn't hold well. So probably it is difficult. So arthroplasty would be, a conversion arthroplasty would be a good option if done and planned well. So probably the last indication I would say is terminal element. You have an X-ray like this or an MRI like this, so probably I am sure there is nothing you can do to fix it. So an arthroplasty in such cases becomes an only mode of therapy. So because you want to give them end of life. I get lots of patients from Tata like this because KEM refuses them, so they come back to New Bombay. So I have to do it. I keep on telling Dr. Ajay Puri, why do you want to surgery? They say that she still has 6 months to 1 year to survive. So if she's walking for that time, you probably should operate. And I can show you one X-ray where there was a breast malignancy. Tata and oncologist gave her 6 months. I asked the patient that should I do a very expensive implant? I will show you the X-ray later. I did an Indian implant. To my bad luck, she survived more than 2 years and she came with a bent prosthesis. And it was a big difficult to salvage that hip. So terminal illness with a lesion in the proximal femur probably becomes an indication for a arthroplasty primarily. So coming to the implant, as I told you, these are very difficult fractures. You have no metaphyseal area which is intact, and you can't, the femur hold is in the metaphysis. So the conventional implants of arthroplasty will not be. So first debate is around hemiarthroplasty. Dr. Milind told you a few things about that. So, but we always, although we know, we have been taught that THR should be done in such cases, but we still do end up, I have so many youngsters and my juniors, even I at times do a hemiarthroplasty, and there is a reason to that, because it is a quick recovery. You do a very simple surgery, you put it in spite of we have been told by textbooks, and in spite of that we have bipolars which are following up after 15 years and they are doing well, in spite of there is vestibular erosions and all that, but they have done well. So I may not be putting up in a conference because there is no literature behind that, but then it is definitely a reason why we do arthroplasties. So there's quick recovery, little risk of mechanical failure, more risk with THR. So you have one more optimum factor, which is cup. It may lose, you may not have a posterior wall, so you tend to do bipolar in such cases. So advantages are there. Disadvantages that I have, in fact, in my 5 years, I have replaced my own 2-3 bipolars which broke, because once they start migrating, or they can have a bipolars, the chances of failures are there over a period of 10 years. Erosion, they are there. So dislocation in THR has been as one reason for these, particularly in trochanteric fractures. So bipolar probably would be, again, monopolar has been preferred in such cases. So it is around 44.5%. So larger head probably may give you more stability. So that's why bipolars are preferred. So coming to THR, obviously in such X-rays, you will probably not think of bipolar because vestibular erosion is there. So a good THR probably would do well. As I told you, there is metaphyseal comminution, loss of bone in both on the lateral side as well as the medial side. So you need to have a special implants for that. So coming to the head size, it has been now all registries probably prefer the green areas 28 and 32. Initially we used to do 40, 44, but it has been very clearly said that there is no advantage of larger heads, and the wear is much more in such cases. So 28 or 32 is the right size to do. Now we have dual mobility cups, which give you the advantage of bigger sizes, but same amount of less wear. So they are being used now more regularly. The next implant is, as I was talking about implants, calcar femoral. Many people with comminuted intertrochanteric fractures would like to do a calcar replacing, but it's not a good idea actually, because there are lots of chances of trochanteric non-union, inequality of, because you have to jam it and you can't do anything. Whatever the calcar size the company provides, that is the size you can do it. So either you have inequality of the limb length, or you probably have a trochanteric non-union if you put it very proud, or so weakness of peripheral soft tissues, again because you have a very large bulky prosthesis proximally. So calcar probably process should be recommended only for proximal tumors and pathological fractures where you can need immediate weight bearing capability. So people are using this prosthesis, but as I told you, it has its own advantages and disadvantages while using them. So you should be aware that if you are using such prosthesis, your limb length should be equal. You should jam it very well. So technically, it is more difficult to use this prosthesis in such fractures. So as I told you, there is no proximal metaphyseal bone. So diphyseal fixation in that case becomes the most important entity in this. So you should always aim at getting a diphyseal fixation in such creation. Again, one of my own cases, this was a bipolar done long back for trochanteric fractures. I think the bipolar was not done by me, but then he came back with a fracture, a periprosthetic fracture. So as I told you, if there is a metaphyseal bone loss, then there is a mismatch between the proximal and the distal. So you need to have a stem which has distal fixation. So there are now, luckily, as I told you, in the market, good implants available where you have the modality, availability of different modalities, so you can probably carry out a good fixation in such cases. So good reassembly of the proximal bone mantle, that is the lesser trochanter and the greater trochanter, becomes an important entity. Don't depend totally on the distal fixation, although it can work for a short duration, but later there might be other problems if you are not reassemble the proximal fragment, proximal bone mass very nicely. Because these are not tumors, they are going to last, they have to live for another 20-30 years, so you need to have a good proximal fixation also. So these are the implants which are readily available, and most of you have seen the last 3-4 presentations. These are the implants being regularly used for a better fixation where you have a metaphyseal comminution. Cemented, I would say that you should probably avoid using, but it gives you definitely immediate fixation, immediate stability. But then if you have to revise such, it's a very, very hazardous surgery if you want to revise this fixation. So coming to cemented and uncemented, it is very clear now, DOR type B and C femurs, they are very wide canal, they are osteoporotic, and so uncemented may not be a good idea in them. But as I told you, we have excellent stems now, which they give a tight fit distally, so they can probably be used. In fact, I have not been using cemented stems for last couple of years now in such cases. As I told you, doing surgeries like over a period of time, I have, and this X-ray is very commonly seen now, where the bipolar done around 8 years, 10 years back has broken. Whether you should blame the implant company or fixation, it is a wide debate. Generally, even if it is well done, an implant company is probably the proximal metaphyseal area, once the lysis start the same, and there is better fixation in the distal part, while the proximal fixation becomes loose, so it starts breaking if you have a very active patient. So then it becomes a difficult thing to revise that. So a good implant should always be invested in. Don't rush to do the surgery with any available implant possible. As against the argument against cementless stems, as I told you earlier also, in very old patients with proximal metaphyseal comminution, completely dissociated proximal metaphysis, a cementless stem probably has more chances of dislocation and failure as compared to a cemented stem, which gives you very early stability. So again, this is a very common thing which you see with youngsters who probably just get a lump of cement there and build up the calcar. Again, this is bound to fail. So my recommendation is probably avoid, rather invest on a good stem which has a distal hold, rather than put a lump and satisfy yourself on table that you have created a calcar and you have got the length and you have got a good fixation. This is all going to fail over a period of time. So a revision becomes very difficult in such situations. So don't use the usual, although AMRs and Thompson processes is a very simple surgery, but if the patient survivorship is very long, probably this is not going to survive. Palliative surgery, as I told you, you have no choice. This is the X-ray on the right side. The oncologist and the Tata people told me that she will not last more than 6 months, but she came back after 2 years with this, and she had no other signs of breast disease. So I was stuck. And then at that time, the relative is telling me, you should have put the best implant that time. And I had already told him that that time he said that no, I would, if he's not surviving, why should I invest? So it is like that. So use the best implant available. Money is not the issue, because they can come back to you and you are going to suffer. Coming to technique, I think I should rush. So proximal comminution, as I told you, no medial support, restoration of length, proper version, abductor support, all these things you have to look. This is not, as I told you, this is not neck femur fracture. If that is a safe and simple surgery, this is the most difficult surgery to do a THR, even in a primary hip. Approach, you choose the best approach you have. If you are well versed with posterior approach, you should do posterior approach. In fact, the approach becomes much easier if you do it posteriorly, because you can even practice trochanteric fixation in a trochanteric osteotomy if you do any other technique later. So it gives you a good vision, but then the whole thing is in a mess. So to reconstruct that, you should have a proper plan. So if you are doing a revision, like you have an old implant, as Dr. Milind said, that you should think of infection. So always take cultures, do a very meticulous dissection. You are going to break the femur if you are going, because this is all fibrosed in a revision surgery. So you have to very slowly develop the plane between the neck trochanter and the anterior wall of the acetabulum, so that you are getting enough retraction and good vision of the acetabulum, so that your acetabulum is well exposed. So be very meticulous, be very slow, and try to do it, particularly people who are not doing it regularly. And the labrum, if you're doing a bipolar, don't excise the labrum. Preserve GT attachments, don't keep on cutting everything, because ultimately you have to reassemble that. Temporarily fix GT and try to restore LT. Even if you have got a very expensive stem, distal hold stem, interlocking stem, you should still try to preserve the proximal bone mass, get it wired together and put it in position, and then you can do a final reaming with all that together. Anti-version is decided by, so focus on this to get a good proper version, because otherwise you have you have no landmarks there. Your GT is separate, your lesser trochanter is separate. So use your limb and assistant to hold it in proper position so that your version is calculated very nicely. And limb length again is a problem, because you don't have trochanter there in position. So limb length becomes an important issue. So you should focus on that. So use your shuck test, or even on a trial implant, see the stability so that you feel. And on your trial implant, do the markings so that you know how much you have to sink and how much you have to. So your fit should be very nice so that you don't over lengthen or you don't shorten the limb. So as again I'm emphasizing, use proper stem. Don't try to cut corners. Don't try to, because your patient is poor and because if this patient is going to come back with a broken stem, or you are supposed to, just 5 days back I got a call from some surgeon who said that there is a bipolar broken and you want to revise it, and he sent me a photo with an Indian revision stem, which is a smooth stem with a small hole in the center. So I said I can't do this. So you are stuck with that, and because patient has no budget for further surgery, so do the first surgery best. So choice of implant, cemented or uncemented, as I told you, there is it is if whatever you are comfortable with. But if your acetabulum is eroded, there is a defect in the acetabulum because of a screw or anything, you would probably need to do a THR only. A trochanteric union may not be achieved in all the fractures, so don't bother about. In fact, in tumors, I just use mesh, try it around the trochanter, fix the whole thing with the mesh. It still works. That is why such patients keep walking. So don't bother about trochanter not uniting. It should be in position, and it should not. It can what is called as trochanteric escape. It can happen there, but you try your best to get it into position and have a bone-to-bone contact, so probably it may unite. But the fibrosis may not allow it to go away. Early and appropriate surgery for hip fracture is the most effective form of pain relief. Whatever you do, whether you do fixation or you do a replacement, the most important goal is to make them walk as early as possible. Thank you very much.